Hello, welcome to case-based learning of cardiac MRI on mricardiac.com. Middle-aged female presented with breathlessness and symptoms of cardiac failure. 2D echocardiography revealed features of restricted cardiomyopathy. These are cine 4-chamber views, which shows presence of low signal intensity thrombotic obliteration of the left ventricular apex. Also note this hypointensity along the endocardial margin. Again, long axis view, as we can see over here, there is apical obliteration only of left ventricle with fibrous tissue deposition. And also note the difference in signal intensity of this thrombus. Late gadolinium enhancement, it shows presence of a layered thrombus along with normal myocardium, then thickened enhanced endomyocardium, and the hypointense signal remains dark even on LG images. All these features are suggestive of endomyocardial fibrosis. These are T1 mapping images, and this is described as double V sign. CT scan images confirms presence of calcification in the thrombus, which was showing hypointense signal on CT image, on the MR images. Lung windows reveal pulmonary edema with fluid overload, and that is the reason why she went into failure. So this tropical endomyocardial fibrosis, there are different theories for pathogenesis, eosinophilia, parasitic disease, autoimmune causes, malnutrition, or other environmental factors are few of them. The disease could either be in acute phase, which clinically presents as febrile illness, pancarditis, or thromboembolic events, or more commonly seen as chronic phase, which presents with restrictive heart failure symptoms, along with hepatosplenomegaly and ascites. Sometime back, due to Kerala fever, there were a lot of cases of endomyocardial fibrosis, which are still being followed up. Classical radiographic hallmark of EMF include apical obliteration of both or either of ventricles, especially with fibrous tissue deposition, and a 3-layer delayed enhancement pattern, as was seen in our case. This sign consists of normal myocardium, then thickened enhanced endomyocardium, and overlying thrombus, which was calcified in our case. Restrictive physiology will lead to dilated atria and shrunken ventricles. Even fibrosis of the chordae tendineae and papillary muscles can also be observed. The disease has multifactorial etiology, and it is also known as Davies disease, or whenever it is with hypereosinophilia, it is described as Loeffler's endomyocarditis. The inflammation into the endomyocardium results into immunomodulation and profibrotic state. And because of this, there is apical obliteration with this thrombotic burden. Various causes have been described, which include from toxoplasmosis, rheumatic fever, malaria, eosinophilia, autoimmune causes, various toxic agents, or even including malnutrition. There are different diagnostic criteria, but more importantly, endomyocardial plaques, which are more than 2 millimeter in thickness, along with that enhancement, that typical 3-layered enhancement is described. The disease is very rare, but it is important to know its radiographic features. Clinical presentations could be either acute, where it could be non-specific symptoms like dyspnea, itching, or any type of pancarditis, or chronic phase when the patient presents with restrictive heart failure. Similar concepts can also be found in our website and textbook Cardiac MRI Simplified. For any feedback and suggestion, please mail us on info@mricardiac.com. Thank you.